Good morning. My name is Guillaume Turc. I am a neurologist from Paris, France, and the current chairman of the ESO Guideline Board. Today, it is my real pleasure to conduct an interview with Dr. Christopher Schwarzbach, who had been working at the University Hospital Mannheim and is now a physician at the Hospital Ludwigshafen in Germany. He is the coordinator of the ongoing SANO study, which is a national multi-center trial on post-stroke care. And he also started working on the Interstroke project in close cooperation with Armin Grau and Martin O'Donnell. And he will present very interesting results on the associations between acute febrile illness, influenza vaccination, and the risk of acute stroke, insight from the Interstroke study.
Yeah, thank you, Guillaume, for introducing me, and thank you for this opportunity to present our results here and to discuss them.
My pleasure. So first of all, what is acute febrile illness? Is there a definition for this, and why should we be interested in this condition?
So we used this definition of acute febrile illness as a self-reported measure within the Interstroke study, which has been systematically assessed. What we are actually looking into is the association of inflammatory disease and stroke. And so inflammatory disease as a potential trigger factor for stroke. However, acute febrile illness is most commonly associated with acute inflammation. So it's reasonable to say that acute febrile illness is a suitable measure, a self-reported measure to detect inflammatory disease. And this is what we did in our study.
Thank you. So you had actually two hypotheses for this study, one about acute febrile illness and another one closely related for influenza vaccination. Could you please tell us a bit more about this?
Yeah, so basically we looked into two associations here. And the reason was, of course, that we had this overwhelming topic of recent years, which of course is COVID-19. And with the emergence of COVID-19, we've seen that the association of infection and stroke gained much additional attention in the last years. And of course, we have several reports which indicated that COVID-19 actually carries an increased risk to develop stroke. And I think that this association is established meanwhile, but also that influenza vaccination is associated with a lower incidence of mortality in COVID-19. However, acute febrile illness and other acute inflammatory diseases have been reported before to transiently increase the risk of ischemic stroke and potentially also irreversible hemorrhage. And on the other hand, influenza vaccination was associated with a reduced risk of stroke in several observational studies and a corresponding meta-analysis. However, all this data is mainly limited to Northern America and Europe, of course, and we have insufficient data when we are looking to other parts of the world. And for the case for influenza vaccination, we also have to discuss that in the absence of randomized controlled trials, these results may also be biased by confounding, especially a so-called healthy user bias, which is a big problem when you look into the association of influenza vaccination and stroke. So here it's also most important to adjust for variables which may also influence the willingness to get vaccinated. And this is what we did in our analysis. So what we hypothesized was that acute febrile illness will be associated with increased risk of ischemic stroke and also intracerebral hemorrhage in different parts of the world. And this was the first hypothesis, of course. And the second one was that influenza vaccination within 1 year will lower the risk of stroke independent of other stroke risk factors we adjusted for.
So what was the methodology that you used to assess such associations? And on which variables did you adjust to make sure that these associations were not confounded?
So what we did is we used conditional logistic regression to calculate odds ratios and 95% confidence intervals. And we adjusted for 13 different variables which might alter the stroke risk. So this, of course, are mainly stroke risk factors like hypertension, physical activity, smoking, cardiac risk factors like atrial fibrillation, but also socioeconomic factors. And what we did too, when we looked into the association of influenza vaccination and stroke, we looked into an extended model into some more variables, which we also adjusted for then, like wealth index, employment status, marital status, and other factors which might be relevant when you look into the willingness to get vaccinated.
What were the main results of your study?
So what we actually found is that acute febrile illness in the preceding 4 weeks was indeed more commonly reported by ischemic stroke patients, namely 8.7% than control subjects, namely 5.6%. And after the adjustment for these 13 variables we just talked about, we found that the adjusted odds ratio was still 1.18. So it's of borderline significance, but it was of significance. And this is, of course, a finding which supports the results, previous results on the association of stroke and infection, even if this association hasn't been that strong in our analysis than before in other analysis which has been reporting or looking into this association. Interestingly, this association was strong, especially when compared to community-based controls with an adjusted odds ratio of 2.0. And these results are actually comparable, also in their quantity, to results reported before on the association of inflammation, acute febrile illness, and stroke. But when we looked into the association to hospital-based controls, the odds ratio was just 0.89, so it's vanished. And this is, of course, an interesting finding, which needs some explanation. And we think that, obviously, acute febrile illness is more prevalent, of course, in hospital-based controls and in community-based controls. Patients are more prone to infection, possibly admitted to hospital with infection. But on the other hand, I have to admit, we cannot rule out that we have an underreporting of acute febrile illness in our community-based controls, as these were self-reported measures which couldn't be verified afterwards.
Causal inference is always a bit difficult in case control studies and in clinical epidemiology in general. What makes you think that the association between influenza vaccination and a decreased risk of stroke is causal rather than confounded? And for example, it might be due to some unmeasured confounders. For example, maybe patients who receive influenza vaccination receive also more medical attention or are more aware of the symptoms of stroke and the risk factors?
Yeah, so actually, this is a big problem. So what you're referring to is the so-called healthy user bias, which is always a big problem when you look into the association of influenza vaccination and stroke. And it's been always a big point of criticism, also in previous reports on this association. And actually, it's hard to address. That's right. So, however, what we try to do here is to also adjust for variables which might influence the willingness of people to get vaccinated. So socioeconomic factors, basically, to address this kind of healthy user bias. So healthy user bias means that, of course, healthy patients who are less prone to stroke are potentially more willing to get vaccinated, and older patients, more frail patients, are usually less vaccinated. So we try to address that, but of course, this is something that we can't rule out. And of course, the best thing would be to have prospective studies on that matter. And this is something, of course, our results also implicate. Yeah? To answer the second part of your question on the association, so on the mechanisms which we suppose take place here, of course, there's this one theory or one hypothesis is that, of course, with influenza vaccination, you might prevent an influenza. As we talked before about the association of acute febrile illness and stroke, this might be a reason why influenza vaccination is effective in preventing stroke. However, what we found is that our results were independent of the seasonality of stroke vaccination. And this was something else which was really surprising for us because, of course, we expected that protective effect of influenza vaccination would be bigger within the influenza season than without, but this wasn't the case. And one explanation might be that, of course, we had many regions of the world where we don't have this kind of seasonality, like in the northern and southern hemispheres. But another result we found is that patients who got vaccinated 5 times in a row over the past 5 years were better protected than patients who got just 1 to 4 vaccinations. And actually, there's another theory, which also been addressed in animal studies, that influenza vaccination stimulates the immune system, and that this stimulation per se, rather than protection of infection, might be a factor in preventing stroke. Not preventing stroke, but lowering the risk of stroke, of course. Perhaps our results can be interpreted in this kind of way. But of course, it's just a hypothesis, and this is something you have to look into, perhaps in further studies, of course.
Thank you. So what would be the single take-home message that you would like people to remember from this very interesting analysis?
I think the most important take-home message is that influenza vaccination, of course, is recommended, especially for older patients, to prevent influenza. But our results also encourage the use of influenza vaccination in a wider scale to lower the general burden of stroke. So our results just encourage the use of influenza vaccination, get vaccinated. That's basically the key message, which we can support by our results.
Thank you very much.
Thank you, Guillaume, for the interview, and thank you for the kind questions and the kind introduction.